As you see, according to the schedule, we were supposed to have a brainstorming session. And I think at my age, brainstorming is dangerous. So I'm going to ask for some thoughts from the younger members of the audience of what their thoughts are about where we should go with this kind of clinical work. Any comments? No young and... Oh. Yes, Dr. Dale.
Are there enough patients with heart transplants for comparisons? Repeat it, please. Are there enough patients who've had heart transplants for me? Are there enough patients with heart transplants for meaningful comparisons?
I would think so. Yeah, I don't. Someone from BSF would know better what the actual number is, but there are quite a few now.
How much of the fatigue is relatable to the heart as opposed to the skeletal muscle, and how much fatty acid metabolism is influenced by having a new heart?
Well, it's at least clear that a number of the boys with normal cardiac function still have severe fatigue. So that's quite clear. Obviously, the heart failure, the heart dysfunction, and can impair getting going, that you cannot upregulate the heart function that much. But it is quite clear that in the presence of normal cardiac function, the boys still have a lot of fatigue, really can have incapacitating fatigue.
You had mentioned that the growth hormone given to the prepubescent boys was not effective and hypothesized that it worked better because of the testosterone at puberty. And I was wondering if anybody supplemented the growth hormone with low-dose testosterone prepubescently.
Yes, I mean, I'm not aware of that. That's definitely something that should be thought about, and that's one of the reasons at this meeting we want to address this directly, because if we can't modify, if the hypothesis is correct and we can't modify growth hormone response dietarily, then we definitely should think of using small amounts of testosterone, because what we want to avoid is a severely debilitating pubertal growth. But I think you can take from the clinical experience that, yes, growth hormone is going to help these boys, and it's a matter of getting a good endocrinologist involved with the group who can come up with some protocols of how to how much to give and how to monitor response.
But it hasn't been tried.
It hasn't been tried, but it's, yes, the experience tells us it should work.
So I have a quick question. Look, based on the data here, it seems those boys are on the trend to develop metabolic syndrome because they have higher total fat mass. They also have, even though non-significant, but it elevated the insulin level. Because they have, so far all the patients being monitored, they're young. So when they, with all the improvement of conditions, if they live beyond, middle age, they might be more predisposed for metabolic complications like diabetes and cardiovascular is already there because the metabolic inflexibility.
Yeah, that's definitely a relevant question. We know of relatively few. We know of a number of young adults now, but not who are getting up in the range where you begin to see metabolic syndrome. One boy who's 30 years old has developed type 2 diabetes and probably would qualify for that diagnosis. So yes, it definitely is something to think about. The boys are fortunately living longer and are going to, may go on to do that. He may be only the first one. However, hopefully the work that we're all doing here can figure out how to address that. And maybe the way Barth studies have helped my patients, perhaps Barth is a good model for looking at, for understanding metabolic syndrome.
I was back to the testosterone. I was wondering if you think it's the rapid growth that's so dangerous, or do you think could it be the testosterone that's so dangerous?
Are you saying could the testosterone be causing trouble, or?
Yes, during puberty.
Yeah, I guess it could be. I don't know. Obviously, that question has not been addressed. We certainly believe it's the testosterone that's inducing the growth. How one would separate the two things is hard to say unless someone were unresponsive to testosterone and growth. But it's clearly we see from I have some tunnel vision with this, I would think, and thinking about it as a nutritional problem. When we look at amino acid abnormalities and muscle mass and prealbumin, it's quite clear that when the boys go into puberty, that whole spectrum of problems gets worse. And when we just intervened on a boy who was going into puberty and was showing cardiac deterioration, and it was interesting, something that we talked about later perhaps, but when we looked at his echocardiograms, one could see that that thinning of the heart was going on for 2 years before his shortening fraction dropped. And this is a compensatory mechanism of the heart. As the heart dilates, the shortening fraction can be sustained at a constant level for a certain period of time. But then it did eventually drop. So we see what I interpret as clear nutritional deficiencies that explain most of the problems that we see in the excessive pubertal growth. I would think that any boy with or without Barth syndrome who grows at that rate is going to have an awful lot of growing pains.
Is there another hormone that could do the same thing as testosterone, but then that's like used earlier in children to sensitize?
Some other hormone that could induce the
Can
growth?
Sensitize, to
Yes.
hormonal action.
I don't know enough about the endocrinology, but the idea is not to virilize them too early, but to this is what you're saying, to get the same effect without virilizing them. And I presume a wise endocrinologist can give us that answer. Oh, okay.
Todd has showed that there's some
yes.
limited benefit of exercise for the boys, and I was wondering that there's some pharmacological ways to boosting mitochondrial biogenesis. So whether that should be tested on the patients in terms of increasing their mitochondrial biogenesis and this sort of equivalent of exercise, but pharmacologically.
Well, there are the fibrates that have some role in biogenesis, and as Todd said, the question is how much, if the mitochondria are so poorly functioning, at least in muscle and heart, how much are we going to get out of increasing the number of those mitochondria, and as opposed to with regard to skeletal fatigue. It clearly works in other mitochondrial conditions that resistance training can produce enormous gains in muscle mass, truly 30, 40 pounds of weight gain over a period of a year or two in boys, usually boys who want to do it, boys who don't want to look so skinny and weak, and they exercise, and the type 2 muscle growth is tremendous. And as you probably all know, most muscles in the body are a combination of type 1 and type 2, so one can increase the type 2 muscle with appropriate exercise. And our physical therapists at Kennedy are gearing up for our clinic to be able to provide that kind of support to those boys. So I think my inclination would be to address the issue about biogenesis in vitro, and Todd and our clinic are going to look at the idea of resistance training. There's some very interesting studies in marathon runners, and it surprised me in looking at that. One thinks of type 2 muscle as being just short endurance muscle, which it essentially is. It has glycogen driven and it runs out of glycogen, but the benefit to marathon runners of increasing to some degree their type 2 muscle is impressive. And so I think quality of life can be improved by looking at that. And Todd hopes he can provide the sort of firm biochemical basis for that. And it's fairly easy to do. Physical therapists are used to doing it for patients with mitochondrial disease. So we'll see how it works out. And I've seen one of the boys I saw yesterday was doing that at home, and he looks pretty good. So it works.
So you showed very interesting data. The TCA cycle is most likely affected in Barth patients. But what is not clear is how cardiolipin affects TCA cycle. And at least in yeast, we have seen that cardiolipin deficiency causes increase in reactive oxygen species. And in your talk, you also said that you supplemented patients with different antioxidants. So what are the antioxidants that you supplemented, and what is the way you supplemented them?
Okay. We treat a large number of mitochondrial disorders in Baltimore, and it's something I've been working on for a long time. And we've come up with a reasonably effective cocktail, and it's not anything novel in the sense that it simply employs, it's recognizing how mitochondria normally deal with reactive oxygen species. And it's simply vitamin E, vitamin C, and coenzyme Q, and that establishes a detoxification cycle. One of the problems in treating free radical disease, so quote unquote, is that the people try lots of coenzyme Q, or they try lots of the C1 quinones, or they try. There's now EPI-743. That's being tried to produce a super antioxidant. The problem is that, for example, vitamin E, if you give huge amounts of vitamin E without anything else, it becomes a pro-oxidant. So that's why one has to design these cocktails quite carefully. So to answer your question more directly, when we treat, we can sort of tell clinically if a child with a mitochondrial disease has an oxidative problem, just looking at the child. It's hard to describe. But we also have other measures of oxidative stress. When we find those abnormalities, for example, coenzyme Q is low in oxidative stress. It's normal in Barth syndrome. And when we treat with this kind of antioxidant cocktail, we virtually always get stabilization of the mitochondrial disease. Now, the children we see are those who typically are mildly developmentally delayed or normal up to a certain age and then develop symptoms. The children who have very severe mitochondrial disease in the newborn period are very difficult to treat. But if the child does reasonably well for 6 months, then that tells me that they're on the edge. And all you have to do is push them back over the edge. And this antioxidant cocktail works very well. It has no effect in Barth syndrome. I've tried, every time I come with a slightly modified, improved version of the antioxidant cocktail, I'll try it on a willing Barth boy, and it's never worked. So even though there are data, as you say, about cardiolipin deficiency causing causing free radical generation, my clinical experience tells me this is not a free radical injury condition. Not that it's zero. It might be mildly increased, but it's not clinically significant in my opinion.
Todd, what do you feel about the utility of exercise in these children with Barth syndrome? I know you had only 3 patients really, so it's not a lot of data, but the main effect you saw is in the quality of life, right? So basically the way they feel about themselves. And do you think this in itself would justify to recommend exercise once you have established that it is safe, even in patients who are predisposed to arrhythmias?
I think overall it has a modest effect. We're talking about endurance exercise training. I think it has a modest effect. So I think it certainly improves their quality of life and their confidence about being able to, engage in such an activity like this. I think that resistance exercise is going to be more effective, and it might be that maybe a combination would be good. But I think certainly remaining active as an endurance exercise, maybe not engaged in an actual program, but certainly engaging in some endurance exercises is probably a good thing. But again, I think resistance training will be more effective as far as increasing exercise tolerance. It won't, obviously won't improve maybe their VO2 or very modestly, but I think overall their ability to withstand exercise and even probably confidence and ability to do more activity is probably going to be more effective resistance training. But that's what hopefully we're going to figure out.
I just have a comment about the question related to antioxidant treatment. it is generally believed that the antioxidant doesn't work in a sense to subdue oxidative stress in the mitochondria, because most antioxidant does not get through the mitochondria in the membrane, because that's where all the free radical being relieved. And related questions that you did treat those patients with antioxidant, and it'll be very interesting to follow up whether after antioxidant treatment, the polyunsaturated fatty acid level come back, because they are the one that most sensitive to free radical damage. And actually, my question was, I've been thinking about, why Mother Nature keep tafficin mutant in human population. It must offer some competitive advantage during evolution, if we believe evolution. And in the sense that you have a large collection so far with patient family, it will be very interesting to study their siblings who are carrier, to see whether, anything we could learn from their sibling, they have a better tolerance for whatever thing. I think clinically this will be most relevant.
Yeah, your point is very well taken, and I can, not related to Barth syndrome, but an example of that kind of thinking. There's a condition we deal with in the Amish, in Mennonites in Lancaster, ANT1 deficiencies, the adenine nucleotide transporter, and it causes a hypertrophic cardiomyopathy, and is in this one extended family. Half of the family lives in Indiana, or quite a few live in Indiana, and quite a few live in Pennsylvania. In Indiana, or in Pennsylvania, and Maryland, the children have slowly progressive hypertrophic cardiomyopathy, and it can even go away in adulthood. And so it's a much milder disease. In Indiana, a lot of the children get transplanted in the first year. And in thinking about this, we were working with Doug Wallace on this, and we measured, we got mitochondrial DNA testing, of course. And sure enough, the Indiana family is haplogroup U3, and the Maryland, Pennsylvania is haplogroup H1. And U3 is a relatively common, it's from Northern Europe, relatively common haplotype, not common, but it's there and it's well known. But by certain assays, it has 30% reduced mitochondrial function in general. And clearly, I think you can argue that made a huge difference in the phenotype. And this is one of the reasons that mitochondrial diagnosis has been so difficult, looking at other mitochondrial diseases. We're finding, when we now have these newer techniques for molecular diagnosis, we're finding patients with clearly a combination of factors, that there's one nuclear gene and a mitochondrial DNA variant that's homoplasmic, carried in the maternal line, but it's the one child who gets the mitochondrial DNA from the mother and the mutation in a nuclear gene from the father. Like we've seen POL-G from the father in a heterozygous state and a mitochondrial abnormality. Sometimes there are some mitochondrial symptoms in the rest of the family. So this is what the newer technology, whole exome sequencing, total mitochondrial DNA sequencing is going to be able to allow us to do. And when I see parents and we talk about how are we going to treat this, and we investigate it, I make that point that understanding the variability in the syndrome is going to give us opportunities for treatment. And now we have, there's protein profiling, proteomics, I guess you call it, and that kind of thing to look at what are the differences. And it's, even though we are getting a better handle on treatment of Barth syndrome, this variability is tremendous. It's not unique to Barth syndrome, certainly, but we see that in other mitochondrial conditions, other genetic factors have a major role in the expression of the defect.
Richard, we'll take one last question and lunch. So I have two related questions. One is just how many patients have you treated with the high-dose arginine, and how many have you classified as responsive? And the related question is that I guess there's a certain fraction that are non-responsive, and clinical cardiac gene therapy is now becoming viable. I'm wondering what your thinking is about developing that as a potential treatment.
I have not seen a lack of response if we can get the amino acid levels normal. And that has been more complicated than I initially thought. The first boy we treated, he went just with arginine alone, with arginine and cysteine, went from ejection fraction of 8% to 43% in 8 months as the only change in therapy. He'd been at 8% for 4 years before that. The problem we've had is that we think part of the retrograde pathway activation leads to an increase in arginase, and it's quite clear that we couldn't get the arginine level up high enough no matter how much arginine we gave some of the boys. And from the ornithine level in the blood, it was obvious it was being broken down in the gut. So we've recently split the dose with citrulline, which is absorbed and then converted into arginine, and it works much better. And we're now getting better success. But what I can say right now is that if we get good levels and we get the prealbumin up into the normal range, they get better. Now that's maybe 4 boys where we have good data right now to say they're getting better, and we have another half a dozen or so that we're still sort of fine-tuning the treatment. It's not, some boys need some methionine as well, and we also found that B6 deficiency was getting in the way, an endogenous B6 deficiency. So it's never as simple as you think it's going to be, but my experience so far, limited to 4 patients, is that if we can really make the amino acids normal, they get better. We've treated a few babies or very young infants now with it, and it's hard to say for sure, but they seem to get better pretty quickly when we straighten out their amino acids.
Fantastic. Richard, thank you for a wonderful morning. And lunches